So I'm a clinician, pediatric neurologist. I've been involved with AHC since the 1980s when I saw my first patient, and been actively involved in helping organize groups of patients to meet together and try to help understand AHC in greater detail. So alternating hemiplegia of childhood, which is abbreviated for as AHC, is a little bit of a misnomer because although it starts in childhood, we see most of our patients grow up to be adults and they continue with their symptoms. So it's a disorder that affects the entire lifespan. In about 20 to 30% of children, the symptoms actually start within a few weeks of birth, but typically most of the patients start at around 3 to 6 months of age. Well, they'll start to have nystagmus, which is jerky eye movements. These are usually transient. They only last for a few seconds or a few minutes, and then the child recovers. Sometimes with this, they will also develop episodes of stiffness or dystonia that we call. These attacks continue until about a year of age, when the child starts to have episodes of weakness on one side of the body. And this is what we mean by hemiplegia. And this is usually flaccid or floppy weakness on one side, and the weakness can be on either side of the body. And very interestingly, what these children develop is that the weakness will start on one side of the body and then progress to the opposite side of the body. And during that period of time, the child will remain totally weak. We call that a quadriplegia. All four extremities are weak, they're floppy, they're not moving. And these are more severe attacks. So during these episodes, the child will remain awake, conscious, but they will have difficulty swallowing and talking. Sometimes these attacks could last only a few minutes. Sometimes their attacks could last for days or even a week. With these episodes, children often have episodes of other abnormal movements. So we talked about the stiffness or the dystonia, but they can also develop what we call choreoathetosis, which is repetitive small movements of the fingers and hands and arms. Often with the attacks, the children might seem to be in pain. So they cry out a very high-pitched cry, seem to be very uncomfortable, irritable, restless, and these attacks continue throughout their life. These children also have delays in their development and in their intellectual abilities. Usually it's mild delays, but this continues to be a persistent problem. As I mentioned, in neurology, everything is in the history, so it's important to take a good history. And then a clinician has to have a certain index of suspicion. So a clinician, how do they prepare to make the diagnosis? I think they have to have knowledge about the condition, read about the condition, maybe saw a patient or heard about a patient previously, and that certainly helps them recognize this disorder. This disorder is extremely rare, so most patients would go on for several years before a diagnosis was made. So certainly the older patients, it took up to 5 years until a diagnosis of AHC was made from the time of the onset of the symptoms. More recently, I think doctors are finding out about AHC, and it's probably within a year or two that the diagnosis is made. When the symptoms first start, because of its paroxysmal nature where symptoms come and go, most of the time the diagnosis is seizures, because that's what we're used to dealing with as child neurologists. That's what it looks like, but after further investigation, it ends up that these are not seizures, and this becomes alternating hemiplegia of childhood. So one has to collect all these symptoms and put these symptoms into a syndrome. So a syndrome is a collection of symptoms. And Dr. Accardi is a pediatric neurologist in France, and he solidified all the diagnostic criteria. So on a clinical basis, we choose all these symptoms and put them together in the syndrome and say, this is alternating hemiplegia of childhood based on the collection of those symptoms. The first step in any diagnosis is clinical. Do these collection of symptoms fit with a specific diagnosis? And it's only in the last 2 years that now we have that gene mutation, the ATPase1A3, that we can do a simple blood test, and in at least about 70 or 80% of the patients, we can confirm a gene mutation. So it doesn't mean the other 20-30% of patients don't have AHC. It means we just have not been able to identify a specific gene mutation. But now it makes our life as clinicians much easier that we can do with a simple blood test identify a highly suggestive test which confirms this mutation. That's correct. So it makes it much easier. It takes out the guesswork out of it. And if you get a positive gene mutation, then it makes this diagnosis extremely probable. The other important aspect of it is that it is helpful to the families because they are frustrated by the lack of diagnosis or a clinical diagnosis. How do we prove it? How do we confirm it? And it also helps to not go on and do all other kinds of maybe more invasive testing like biopsies to look for possible causes for the child's alternating hemiplegia. So now that we have the simple genetic blood test, it's much more gratifying for the physician as well as the family to be able to precisely say this is what the diagnosis is. As far as diagnosis, another problem is that when these children have their symptoms, they're very dramatic. Often, though, they would come in and visit with a doctor and they seem fine. So it's hard for the doctor to conceptualize when a parent is telling them, my child can't move on one side, and when they're in the doctor's office, they're perfectly normal. So this also, in some ways, interfere with the early diagnosis of this condition. And so I think with any kind of transient movement abnormalities like this, it's good to get videotapes of what your child is doing so you could show the doctor, and then he would stop and think, hey, something strange is going on. And as was suggested by Dr. Swoboda, we're all curious. When we see something that doesn't fit with what we think should be going on, either we'll dismiss it because we're busy, or we'll say, oh my goodness, I've never seen anything like this, and let me look into it further. So it's very important to do that videotaping of the symptoms. I actually work at the University of Chicago, so I've been on staff there. My initial interest in alternating hemiplegia of childhood started in Montreal, Canada, and that's where I was on staff and worked closely with Dr. Anderman. and then I moved to Chicago, and at I think one of these meetings, Dr. Swoboda came, and we decided over 10 years ago to have a collaboration. So she is in Utah, I'm in Chicago, but we meet at the meetings and try to collaborate on research and data collection. I think that the discovery of the gene that is responsible for alternating hemiplegia of childhood opens up a whole new world, as we were talking about previously, that over 40 years since AHC was first reported in the literature, we were getting to be very frustrated by the lack of progress, by the lack of identification of a cause, by the lack of finding a genetic explanation for this, by the lack of finding a very good treatment to prevent the attacks. And now with the discovery of the gene, we have a better pathway to do research, both basic science research in laboratories as well as clinical research in patients. Now that we know the gene, we understand more and more about the gene as new information is being accumulated since that gene was discovered, that I think advances will progress more rapidly. It originally started with one patient. I was at that time working in a clinic, and so I would go visit these patients in this clinic, and then on one day this teenage girl was having a seizure that the nurse brought to my attention, but the seizure when I saw the child was weakness on one side of the body. And then when I would go back to this clinic a week or two later, they would call me again that the patient had a seizure. No one witnessed the seizure, but when I went to examine the child again, this time the weakness was present on the opposite side of the body. So this didn't make much sense to me for a manifestation or a form of seizures. And actually, when I went and read through the records, I had seen that my colleague, Dr. Anderman, had seen this patient many years previously. He didn't make the diagnosis of alternating hemiplegia because very little was known about the condition at that time. But then when I brought it to his attention, he instantly remembered the patient and instantly remembered that there was a paper written in 1971 by Canadian neurologists called Verrett and Steele, who reported the first few cases. So that started us on the road to interest and treatments for patients with alternating hemiplegia of childhood. Over the last several decades, initially working with Dr. Anderman and more recently working with Dr. Swoboda, we've collected information on hundreds of patients and identified their clinical manifestations, their drug treatments and their responses. And I think the most dramatic important information is the discovery of the gene, the A1A, the 1A3 gene that is found to be responsible for most of the cases of alternating hemiplegia. So that was 2 years ago now, and I think that's probably one of the most exciting new developments in knowing about AHC. I think patients are always teaching us things. I think physicians are generally very busy, don't always sit and listen to their patients. And that is the most important thing in neurology. We take a history and we listen to the patients about what they describe and the manifestations of the disease. So certainly in all these meetings, every patient is different and we learn from our patients. We interview many patients every meeting. Some are new patients who've just recently diagnosed alternating hemiplegia, or this was their first opportunity to come to the meeting, and we interview them, we examine them, try to help confirm the diagnosis, draw blood for obtaining material for genetic analysis to confirm the gene mutation. And then all that data is correlated in a database that Dr. Swoboda keeps at the University of Utah. So in the past, we've looked at all the data as far as manifestations of time of onset of their symptoms, what their eye symptoms are like, what their hemiplegia is like, what their dystonia is like, what their developmental outcomes are like, what medications they respond to, and all this is kept in a database, and we try to correlate it. And in fact, with Dr. Sweeney as the senior author, we published that information in Pediatrics in 2009. We've worked very hard over decades to try to find the best diagnosis and treatment. And now we have even a better understanding of the basis of this condition with discovery of the gene mutations in AHC. The next step would be to further research, firstly in the basic sciences, to find out what this gene mutation does to the brain, how does it cause the symptoms of dystonia and weakness and seizures and headaches, and then how do we apply that knowledge and treatment to the patient. So this is still many years, if not decades, of research into the future. And all this requires identification and support through sponsors, benefactors, to help support this research into finding out better treatments for children with AHC. Many of the alternating hemiplegia of childhood groups have their own gatherings, their own fundraising, local chapters in North America. But these are people who already know about alternating hemiplegia of childhood. And it's true in many countries in Europe. Now in Japan, they're looking at larger and larger groups of patients, especially now that the gene has been discovered and it's easier to identify these patients. So there are increased interest in that respect, and I think we're going to see a lot more publications in the medical communities. The patients, the publicity about patients that I think you want to promote, especially with identification of the condition, would be probably to pediatric neurologists and epilepsy doctors. And so all over the world, there is always meetings, annual meetings in different areas around the world with epilepsy, international epilepsy societies, international child neurology societies, and often in those meetings, they would have like little kiosks where people would try to promote specific ideas, products, and also disease specific organizations would try to help encourage the identification of these conditions and teach people about what the condition is. And so to set up a booth in one of these meetings might be helpful to spread the word amongst child neurologists and or epilepsy doctors who more likely would be the first ones to see a child with alternating hemiplegia because they present as seizures, at least thought of as having seizures. So they're the ones that I think would be most important to educate, and that would be a good venue because sometimes in these meetings there are hundreds, if not thousands, of doctors that attend these meetings. I think that, if I remember correctly, we've seen patients into the late 50s. We did try to find the original patients reported by Verrett and Steele in 1971 when I was living in Canada, but we were not able to track them down.